Okay, would not hamper our class, but
Okay.
so yes. Question number 1 out of 15. A patient who was waiting in an inguinal hernia repair, awaiting an inguinal hernia repair is found to be positive for MRSA after screening at the pre-admission clinic. What treatment should he be offered, if any? So this was the last question maybe we were doing. Nasal fusidic acid plus chlorhexidine for the skin. Nasal mupirocin plus triclosan for the skin. Nasal mupirocin plus chlorhexidine for the skin. Nasal chlorhexidine plus chlorhexidine for the skin. No treatment but
I think
admit
this
to the
one
side room.
yesterday we did, no?
Yeah, we did this
Okay.
question, yes.
Yeah,
So we
third
want
one.
a very quick answer. Yeah, nasal mupirocin and chlorhexidine for the skin. 27-year-old Jack is on methadone 60 milligrams once a day to manage his symptoms from heroin withdrawal. He collects his methadone daily from the pharmacy and is supervised consuming it. One Wednesday morning, Jack fails to turn up to the pharmacy. What is the most appropriate course of action for the pharmacist? So, one, give him his usual 60 milligrams methadone when he turns up next day on Thursday and forfeit the dose from the day before. Give him 120 milligrams methadone when he turns up from the next day on Thursday and 60 milligrams for Wednesday and 60 milligrams for Thursday. That is, give him his usual 60 milligram methadone when he turns up on the next day, but offer him another 60 milligrams to take later in the day. Ask the patient to book an appointment with the GP to consider lowering his usual dose and he has not suffered any withdrawal symptoms on Thursday from missing his usual methadone dose the day before. Give him his usual 60 milligrams methadone when he turns up next day on Thursday and give him an additional 30 milligrams, half of the Wednesday dose. So this is when opioid withdrawal, so heroin withdrawal. So when a patient wants to de-addict from heroin, he is prescribed methadone, and this methadone he has to collect every 2 days or maybe on the same day, every day from the pharmacy. So what happened, this person Jack, he did not come to collect his dose on Wednesday and he comes on Thursday. So when he comes on Thursday, what is the uh, instruction for the pharmacist, what he should be doing it, the pharmacist should be doing? Any answers, doctors?
I guess four. First option. No. First one.
Hmm.
Give
First
him
option.
his usual dose and don't give any other dose.
Yeah, and forfeit the dose from the day before because he did not require it on that day, right? And he did not even have withdrawal symptoms for a day. And methadone, this withdrawal of symptoms of heroin won't come after one skipped dose of methadone. So there was something like that. We'll see in the explanation as to what was the correct explanation. But even I think this is the correct answer. So let's go with this. So give him his usual 60
Good.
milligrams methadone dose. Good answering, doctor. When he turns up next day on Thursday and forfeit the dose from the day before. Why? We have to see this. Methadone is a long-acting synthetic opioid analgesic. Because it's long-acting, it acts as a full opioid agonist. It is used in the treatment of opioid dependence as a support in detoxification. The peak clinical effect of methadone is 2 to 6 hours post-oral dose, and the half-life of methadone is around 15 hours. It takes approximately 5 days for plasma levels of methadone in the body to stabilize. There is a cumulative effect until steady state is reached, and after that, variations in blood level of methadone are small. Methadone is metabolized to liver via the P450 enzyme system. Due to the cumulative effect of methadone, should be prescribed starting at a low dose and titrating upwards. Methadone is typically taken once daily. The standard concentration is 1 milligram per ml oral solution. The starting dose of methadone should be around 10 milligrams to 30 milligrams daily depending on the amount of heroin, the length and method of use of heroin and other opioids being used. Missed doses can cause opioid withdrawal syndrome after 2 to 3 days. See, it does not cause immediately on the next day. That's why this person Jack was fine on Thursday even if he missed one dose. 2 or 3 days, as this is how long it takes for the blood levels of methadone to normalize. For this reason, the GP does not need to review the patient who has missed a dose of methadone unless they have missed 3 or more consecutive days. Should they have missed 3 or more consecutive days and still have no symptoms of opioid withdrawal, an assessment can be made whether to reduce the dose of methadone would be appropriate. So this is we are giving them this opioid receptor agonist to help in tackling the withdrawal symptoms of heroin withdrawal. So if the patient missed 3 doses consequently, if he was feeling any withdrawal symptoms, he would come and take his dose. So he is not feeling that is implied he is not feeling any withdrawal symptoms also after missed 3 doses. Then the GP should consider whether the dose of methadone should be reduced. The patients also repeatedly missed doses should have their treatment reviewed. Any missed methadone dose should not be replaced and is forfeited by the pharmacist. Opioid misuse. Opioids are substances which bind to opioid receptors. This includes both naturally occurring opioids such as morphine and synthetic opioids such as buprenorphine and methadone. Features of opioid misuse. Rhinorrhea, needle track marks, pinpoint pupils, drowsiness, watering eyes and yawning. Complications of opioid misuse. Viral infection secondary to sharing needles, HIV, Hep B, and Hep C. Bacterial infection secondary to injection, infective endocarditis, septic arthritis, septicemia, necrotizing fasciitis, venous thromboembolism. Overdose may lead to respiratory depression and death. Psychological problems like carving. Social problems like crime, prostitution, and homelessness. Emergency management of opioid overdose. When there's an opioid overdose, you have to give them IV or IM naloxone. This has a rapid onset and relatively short duration of action, so repeated doses of naloxone will be required. Harm reduction interventions may include needle exchange or offering testing for HIV, Hep B, and Hep C. So you have to give them exchange needles for people who are addicted to reduce the harm of using multiple use of the same needle and offering for testing for HIV, Hep B, and Hep C. Management of opioid dependence. Patients are usually managed by specialist drug dependence clinics, although some GPs with a specialist interest offer similar services. Patient may be offered maintenance therapy or detoxification. NICE recommended methadone or buprenorphine as the first-line treatment of opioid detoxification. Methadone is a full agonist of the mu opioid receptor. M for methadone, M for mu. Mu opioid receptor agonist and binds to these receptors in the brain, fully activates them. This action can relieve withdrawal symptoms and carvings. It has a long half-life. Buprenorphine is a partial agonist of the mu receptor and an antagonist of the kappa opioid receptor. So this binds to the mu opioid receptors in the brain but only partially activates them. This partial activation is enough to alleviate the carvings of withdrawal and symptoms of individuals with opioid dependence. Furthermore, the binding of buprenorphine to the mu opioid receptor is very strong and high affinity, meaning it can displace other opioids from these receptors and prevent them from exerting their effects. As kappa opioid receptor antagonist, buprenorphine may contribute to its ability to reduce symptoms of opioid withdrawal and potentially reduce its depressive and dysphoric states. So this has dual action. Buprenorphine. Compliance is monitored using urine analysis. If he is taking methadone or buprenorphine or not is monitored by urine analysis. Detoxification should normally last up to 4 weeks in an inpatient or residential setting and up to 12 weeks in the community. So we're going for the third question, a very nice question. Heart failure drug management. Pneumococcal vaccine, influenza vaccine, calcium channel blocker, spironolactone, ACE inhibitor, beta blocker, hydrolysin nitrates, ACE inhibitor, furosemide, digoxin, echo, electrocardiogram. Should, for each one of the following, select the most appropriate answer. Should be offered annually for all patients with heart failure. What we should give annually, doctor? Annually, we are speaking of vaccines only. Yeah, influenza vaccine. Because even if pneumococcal vaccine was supposed to be given, it will be one off or 5 yearly, right? Should be introduced first line in patient with stable impaired left ventricular function. Which one? First line for stable impaired left ventricular function. That is low ejection fraction, heart failure. ACE inhibitor plus beta blocker, hydrolysin plus nitrates, ACE inhibitor plus furosemide. So first line in heart failure is ACE inhibitor. What about beta blocker or furosemide? Which one is the first line?
AC inhibitor. AC inhibitor and furosemide? No.
Why, doctor?
Because I feel beta blocker will be harmful in left ventricular function, impaired left ventricular function.
Yes. Yeah. Has
So
fluid.
summary for the acute, this one we are giving, no, for acute fluid overload. So I think it's ACE inhibitors or beta blockers.
Yes, furosemide and pulmonary edema. Split.
Okay, let's see.
Plus beta blocker. I will go with that.
Okay, let's see. We are marking ACE inhibitors and furosemide and we'll see the answer. Only has been demonstrated to improve mortality in patients with NIHA class 3 or class 4 heart failure who are already taking an ACE inhibitor. Which drug has been demonstrated to improve mortality in patients with NIHA class 3 or class 4 heart failure?
Digoxin? No, spironol.
Yeah, we need a refresher for this because
Yes.
even I forgot. It was long back. So digoxin, I'm thinking it's digoxin, but let's see.
Will not increase. It will not increase the mortality. It is giving in atrial fibrillation if there is a stated.
Yes, he is he is correct.
Yeah. So
Spironolactone even, I don't know, we'll go with the second class, that is among calcium channel blocker or beta blocker.
beta blocker alone is not there in our option. So calcium channel blocker. Okay. So let's see. Should be offered annually is influenza vaccine. Should be introduced first line in patient with stable impaired left ventricular function is ACE inhibitor and a beta blocker. Has only been demonstrated to improve mortality in patients with NIHA class 3 or class 4 heart failure who are already taking ACE inhibitor is spironolactone. Okay, we will see chronic heart failure drug management and then it's a refresher for us because we have already done cardiology, right? NICE issued updated guidelines on the management to 2000. Where were we? Management in 2018. Key points are summarized here. While loop diuretics play an important role in managing fluid overload, should be remembered that no long-term reduction in mortality has been demonstrated from loop diuretics such as furosemide. So mortality is not reduced by furosemide. So here improving mortality. So furosemide will not be the answer here. While first line therapy for chronic heart failure. First line treatment for all patients is both ACE inhibitor and a beta blocker. So that is first line. Generally, one drug should be started at a time. NICE advice that clinical judgment is used when determining which ones to start first. Beta blocker licensed to treat heart failure in UK include bisoprolol, carvedilol, and nebivolol. ACE inhibitors and beta blockers have no effect on the mortality in heart failure with preserved ejection fraction. But here it was reduced ejection fraction, right? Stable but reduced ejection fraction. Where was our question? Yeah. Stable impaired left ventricular function. That is stable reduced ejection fraction. ACE inhibitors and beta blockers have no effect on mortality in heart failure with preserved ejection fraction. Second line therapy. Second line treatment is aldosterone antagonists. These are sometimes referred to as mineralocorticoid receptor antagonists. Examples include spironolactone, eplerenone. It should be remembered that both ACE inhibitors, which in patient is already on, and aldosterone antagonists can cause hyperkalemia. Therefore, potassium should be monitored. There is an increasing role of SGLT2 inhibitors in the management of heart failure with reduced ejection fraction. These drugs reduce the glucose absorption, increase urinary glucose excretion. Examples include canagliflozin, dapagliflozin, and empragliflozin. The evidence base shows that SGLT2 inhibitors reduced hospitalization secondary to heart failure and cardiovascular death. International guidelines widely recommended usage in terms of NICE, a technological appraisal from 2021 support the use of dapagliflozin as an add-on to optimize standard care in heart failure with reduced ejection fraction. Third line therapies. Third line treatment should be initiated by a specialist. Options include ivabradine, sacubitril valsartan, hydralazine, combination with nitrate, digoxin, and cardiac resuscitation therapy. Ivabradine, the criteria for using ivabradine would be sinus rhythm more than 75 and a left ventricular fraction less than ejection fraction less than 35%. Sacubitril valsartan criteria left ventricular fraction less than 35 is considered in heart failure with reduced ejection fraction who are symptomatic on ACE inhibitors or ARBs. Should be initiated following ACE inhibitor or ARB washout period because see, sacubitril and valsartan. Valsartan is again an ARB, right? So it should be initiated in those who are having who are symptomatic on ACE inhibitors or ARBs. In those people, we have to initiate sacubitril or valsartan after an initial washout period, because these are both ARBs, right? So the first ARB should be washed out, after which the new drug should be introduced. Digoxin. Digoxin has not been proven to reduce mortality in patients with heart failure. It may, however, improve symptoms due to its inotropic properties. It is strongly indicated if there is a coexistent atrial fibrillation. Hydralazine in combination with a nitrate. This may particularly be indicated in Afro-Caribbean patients. This is one thing that is peculiar. Hydralazine with a nitrate is indicated in Afro-Caribbean patients. Cardiac resynchronization therapy indications include a widened QRS complex, that is left bundle branch blocks complex on ECG. Other treatments offer annual influenza vaccine, one-off pneumococcal vaccine. Adults usually require one dose, but those with asplenia, splenic dysfunction, or chronic kidney disease need a booster every 5 years. So this was a chronic heart failure management flow chart. Chronic heart failure diagnosed by a specialist. Then, once it is diagnosed by a specialist, offer diuretics for congestive symptoms and fluid retention. After that, if then you will classify. First, patient has come to you with heart failure. Give them a diuretic. After that, give them classify them according to heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. If the ejection fraction is preserved, manage comorbidities such as hypertension, atrial fibrillation, ischemic heart disease, and diabetes in line with NICE guidelines. So, if ejection fraction is preserved, that means the heart is pumping fine, sufficiently, so you don't have to give any specific or special medicines. So manage only the comorbidities such as hypertension. What has caused heart failure? Hypertension, atrial fibrillation, ischemic heart disease, and diabetes in line with the NICE guidelines. So whatever these comorbidities are, you manage according to its NICE guidelines. Then offer a personalized exercise based cardiac rehabilitation program unless the condition is unstable. Okay. So then, in case the patient has been classified as heart failure with a reduced ejection fraction, offer an ACEI or BB or a beta blocker, an MRA if symptoms continue. So, ACE inhibitors and beta blockers are first line. Then, mineralocorticoid receptor antagonist if symptoms continue. This is spironolactone. After this, again personalized exercise-based cardiac rehabilitation program unless the condition is unstable. If MRA, if on these three drugs they are still symptomatic, consider ARB if intolerant to ACE. So ACE inhibitors is first line. If they are intolerant to ACE inhibitors, consider an ARB, that is angiotensin receptor blockers. Then consider hydralazine and nitrate if intolerant to ACE inhibitors or ARBs. Hydralazine and nitrate, also in Afro-Caribbean patients we will consider hydralazine and nitrate. So after that, if after they have been given the drug treatment and after they have been put on cardiac rehabilitation program, next, if the symptoms persist despite first line treatment, seek a specialist advice and consider one or more of the following. Replace the ACE inhibitor with sacubitril. This is the third line drugs. So after rehabilitation, still their symptoms are persisting, you go for the third line drugs. First is replace ACE inhibitors or ARBs with sacubitril and valsartan if ejection fraction less than 35, ivabradine with sinus rhythm more than 75 and ejection fraction less than 35, because ivabradine will decrease the heart rate. So if heart rate is less than 75, you are not giving ivabradine. You have to look for another alternative. If heart rate is more than 75 and ejection fraction is less, you can give ivabradine. Again, hydralazine and nitrate, especially if Afro-Caribbean descent. And then digoxin for heart failure with sinus rhythm to improve the symptoms. And yeah, measure the serum sodium, potassium, and assess renal function before starting and after each dose increment, that is valsartan. For valsartan, if eGFR is 30 to 45 ml per minute, consider lowering the dose and or slower titration of ACE inhibitors, ARBs, MRAs, sacubitril, valsartan, and digoxin. All these drugs you have to lower the doses or slower titration if GFR is 30 to 45. That is I think grade 3B. 3B, class 3B, kidney failure. So we are clear with this management, doctors? Are we clear?
Yes, doctor.
Yeah.
Yes, doctor.
So now we have no doubt. You are managing heart failure, drug management. The question comes only when there is reduced ejection fraction. When there is no reduced ejection fraction, you will treat only the comorbidities. Okay? There's no confusion with that. And when you are treating heart failure with reduced ejection fraction, which requires treatment, in that case, ACE inhibitors and beta blockers, A, B are first line. After that will be MRA, and then after that, these two are first line and second line drugs. And then in between, there will be one more drug that will be SGLT2 inhibitors. And then after that, there will be third line drugs, which are sacubitril valsartan, hydrogen nitrate, ivabradine, or digoxin. These are third line. So can we go back to the question and see if we have understood everything clearly? NIHA has
Okay.
this drug should be introduced first line in patient with stable impaired left ventricular function. Yes, ACE inhibitors and beta blockers, right? Furosemide is not there here. Has only been demonstrated to improve mortality in patients with NIHA class 3 or 4 heart failure who are already taking an ACE inhibitor. So person is taking ACE inhibitor and still he has NIHA class 3 or class 4 heart failure. Next line would be spironolactone. Because demonstrated to improve mortality will be spironolactone. Beta blocker does not improve mortality. That is one point about beta blockers. So ACE and beta blockers should be given, but beta blocker does not improve mortality. Only thing that will improve mortality is next line is spironolactone. So yes, that is a picture, and we want an that's a spotter. 23-year-old woman who is 10 weeks pregnant presents rapidly growing with a rapidly growing lesion on her finger. This has grown from the size of a pinprick when it was first appeared 4 weeks ago. What is the most likely diagnosis? Is it a viral wart? Is or pyogenic granuloma, capillary hemangioma, squamous cell carcinoma?
Pyogenic granuloma.
Yeah,
It are like, first it will be like,
yeah, pyogenic granuloma. We will yes. So, pyogenic granuloma is relatively common benign skin lesion. The name is confusing as it's neither true granuloma nor pyogenic in nature. There are multiple alternative names, but perhaps eruptive hemangioma is more useful. The cause of pyogenic granuloma is not known, but a number of factors are linked. Trauma, pregnancy, more common in women and young adults. So, looks like this, or this looks like a hemangioma, right? Eruptive hemangioma looks like a hemangioma. This one looks less like a hemangioma, but just remember. And this one is very small, but it is a pyogenic granuloma. Looks like a hemangioma also. It's reddish. So, most common size are head and neck, upper trunk, and hands. Lesions in the oral mucosa are common in pregnancy. Head, neck, upper trunk, hands, oral mucosa. Initially small red-brown spot, rapidly progresses within days to weeks, forming a raised red-brown lesion, which are often spherical in shape. The lesions may bleed profusely or ulcerate. Management. Lesions associated with pregnancy often resolve spontaneously postpartum. Other lesions usually persist. Removal methods include curettage, cauterization, cryotherapy, and excision. Question number 7 to 9. Childhood infections. Shingles, rubella, chickenpox, scarlet fever, Coxsackie A16, parvovirus, measles, mumps, meningococcal septicemia. The prodrome is characterized by fever, irritability, and conjunctivitis. What could be?
options.
Yeah, these are the options. Fever, irritability, and conjunctivitis. What causes these three?
Measles.
Measles, right?
Measles, conjunctivitis.
Measles will cause cough, coryza, and conjunctivitis. I think measles. May cause vesicles in the mouth and on the palms. Coxsackie A16,
Yeah.
right? Hand, foot, mouth disease.
Hand, foot, mouth.
True.
May cause a crop of white spots on the inside of the mouth. White spots are
Coptic spots. Mumps.
Yeah,
Mumps.
Koplik spots is measles.
Measles. Measles. Yes, go like this.
Yeah, you all are correct. So no explanations then. Next question. 9-month girl is generally unwell with low-grade pyrexia, oral ulcers, and the following appearance on her feet. So she has pyrexia, ulcers in the mouth and feet also. So this is hand, foot, mouth disease. Organism is
Yes, repeating.
Yes.
yes. Just give me a minute, doctor. Okay, next question. We read the explanations yesterday, doctor, so we are not repeating that. You see a 10-year-old child in your surgery with fever, rash, strawberry tongue, and make a clinical diagnosis of scarlet fever. Within what time frame does Public Health England state you must submit a notifiable disease form? After laboratory confirmation, same working day, not a notifiable disease, 72 hours, 1 week. Same day, right?
Same working day.
Or 72 hours. Here in UAE, you have to notify anything within a week. But maybe in UK, maybe same working day. Let's go with it. 72 hours. Scarlet fever is notifiable disease. So any notifiable disease you have to inform within 72 hours. It is statutory duty of the clinicians to inform the local health protection team of suspected or proven cases of notifiable diseases. There is no need to wait for laboratory confirmation before making the notification. Public Health England states that relevant forms should be completed straight away upon seeing suspected cases of notifiable disease, and the form should then be submitted within 72 hours. Verbal notification to be made within 24 hours in case and if the case is an emergency. Okay, 72 hours and verbal notification within 24 hours. So we know all the notifiable diseases, right? We will just see what are not notifiable. In April 2010, these were like HIV is not notifiable. Other five diseases which were removed from the list of notifiable diseases: dysentery, ophthalmia neonatal, leptospirosis, and relapsing fever. All of these are not notifiable. Rest all vaccine preventable diseases, all communicable diseases, SARS, um, COVID, all of these zoonotic diseases, all of them are notifiable. You are reviewing a 73-year-old patient with a new diagnosis of heart failure. Based on his recent echo, he has shown left ventricular ejection fraction of 35%. He has been complaining some mild exertion, shortness of breath. He has no other medical problems and is not yet on any regular medication. So he's not taking any regular medication. Huh? And which of the following is most appropriate or advised to offer? Yearly influenza and pneumococcal vaccines, one of pneumococcal vaccine, yearly influenza vaccine, yearly influenza and one of pneumococcal vaccine, and meningococcal vaccine, he's saying.
Fourth one.
Yearly influenza and one of pneumococcal vaccine.
Fourth one.
Meningococcal also, doctor?
I think last one, Doctor. Yearly influenza and one of pneumococcal.
Even I'm thinking
Last
that.
one. Last one. Last one.
Last.
But why doctor is
Yes.
saying meningococcal vaccine?
Meningococcal, pneumococcal.
No, I got it like that. These leafy parts.
Okay. Yearly influenza and one of pneumococcal vaccine. Patient with diagnosis of heart failure should have an yearly influenza vaccine and one of pneumococcal vaccine because it does not follow the criteria of 5 yearly pneumococcal vaccine, right? Only for chronic kidney disease, asplenia, and splenic dysfunction. You will give five yearly. A farmer presents with a tender lesion on his finger. This one. What is the most likely diagnosis? It is not.
Or
Yeah, paronychia, orf, tetanus, anthrax, hand foot mouth disease. Hand foot mouth disease not. Anthrax doesn't look like anthrax. Anthrax will be black crusted lesions. Sorry, black crust like lesions, not crusted. Tetanus, the hand will be fully swollen. Looks like orf. Not paronychia. Paronychia will be having yellowish pus oozing out. So it's off. Also known as contagious ecthyma is a genetic disease caused by parapox virus that primarily affects the sheep and goats. Humans can contract the disease through direct contact with the infected animals or via fomites. The typical presentation includes a painful red nodule on the hand or finger, often with a central ulceration. So can you see the central ulceration here? And red painful nodule. Where were we? Where were we? This aligns with the farmer's occupation and clinical picture presented. Anthrax is another zoonotic disease caused by Bacillus anthracis. Cutaneous anthrax usually presents as a painless black eschar after an incubation period of 1 to 7 days post exposure. However, in this case, there is no mention of exposure to livestock products such as hides, wool, which would increase the suspicion of anthrax. ORF. ORF is generally a condition found in sheep and goats thought to be transmitted to humans. It is also caused by parapox virus in animals, scaby lesions around the mouth and nose. In humans, generally affects the hands and arms, initially small raised red-blue papules, later may increase in size to 2 to 3 centimeters, become flat-topped and hemorrhagic. ORF is also one of the causes for erythema, erythema
Multiform.
multiforme. Yeah, multiforme. Which one of the following congenital infections is most characteristically associated with sensory neural deafness? Toxoplasma gondii, parvovirus B19, rubella, treponema pallidum, and group B streptococcus. Rubella, doctors?
Yeah, Rubella.
Rubella, yeah.
Right?
Yeah.
Congenital syphilis will cause Hutchinson teeth and other problems. Toxoplasma will cause, I think, microcephaly, but I don't know what. Parvovirus B19 is not implicated, right, in any congenital infections.
In any congenital disease.
Group B streptococcus,
No, not
No,
yet.
no.
we'll see what it will cause. Congenital rubella, sensory neural deafness, and congenital cataracts. Sensory neural deafness, congenital cataracts is congenital rubella. Answer is rubella. Congenital rubella syndrome is characteristically associated with sensory neural deafness along with other abnormalities such as cataracts and cardiac defects. This is due to the virus' ability to cross the placenta and infect the fetus during pregnancy, particularly during the first trimester when organogenesis occurs. The virus can damage the cochlea leading to sensory neural deafness. Toxoplasma causes congenital toxoplasmosis, which can lead to severe neurological complications such as hydrocephalus, intellectual disability. However, it is not specifically associated with sensorineural deafness. Parvovirus B19 infection in pregnant women can cause hydrops fetalis. Okay, we thought it doesn't cause anything. But parvovirus B19 infection in pregnant women can cause hydrops fetalis, a severe form of fetal anemia that leads to heart failure and fluid accumulation in the fetus. Sensorineural deafness is not a characteristic feature of parvovirus B19 infection. Okay, in children it causes sixth disease, right? No, fifth disease,
I
right?
think fifth
Fifth
disease, not
disease.
sixth. Fifth.
Fifth
Okay.
disease, that is slap cheek syndrome, right?
Yes, slap cheek
Slap cheek.
syndrome.
Yeah. Roseola infantum or slap cheek syndrome. But in pregnant women, it can cause hydrops fetalis. It's very severe, it is very dangerous in pregnant women then. Treponema pallidum causes syphilis, can be passed from mother to baby during pregnancy, resulting in congenital syphilis. This condition may present with various symptoms, including hepatosplenomegaly, rash, and skeletal abnormalities, but does not typically cause sensory deafness. So, treponema pallidum will cause hepatosplenomegaly, rash, and skeletal abnormalities. Group B streptococcus infection can lead to neonatal sepsis or meningitis. While meningitis could potentially result in hearing loss if left untreated or if treatment is delayed, GBS infection is not characteristically associated with sensorineural deafness like rubella. Congenital infections, we have group of congenital infections here. Cytomegalovirus is the most common congenital infection in the UK. Maternal infection is usually asymptomatic. Characteristic features: rubella, sensory neural deafness, congenital cataracts, congenital heart disease, patent ductus arteriosus, and glaucoma. Four things: sensory deafness, congenital cataract, heart disease like PDA, and glaucoma. Other features: growth retardation, hepatosplenomegaly, purpuric skin lesions, salt and pepper chorioretinitis, microphthalmia, and cerebral palsy.
But in paper means that it will cause like a burning sensation in eyes or what?
No, it will have a picture of white and black. chorioretinitis,
Okay.
microphthalmia, and cerebral palsy. So microphthalmia will be there, and hepatosplenomegaly will be there in all the three. See, cytomegalovirus, toxoplasmosis, rubella, all three will have hepatosplenomegaly, and also congenital syphilis will have hepatosplenomegaly. So that is
Even cerebral
common.
palsy is also.
Cerebral
All
palsy is
three.
also common for all the three, right? I think chorioretinitis is also common, but it's not here. Okay, fine. Yeah, chorioretinitis, see here, toxoplasmosis, it's here, not there in cytomegalovirus. So that is about rubella. About toxoplasmosis, cerebral calcifications. Toxoplasma gondii will cause calcification, chorioretinitis, and hydrocephalus. Anemia, hepatosplenomegaly, and cerebral palsy. Cytomegalovirus will cause low birth weight, purpuric skin lesions, sensory neural deafness. Again, CMV will also cause sensory neural deafness, as akin with rubella, and microcephaly. Visual impairment, learning disability, encephalitis and seizures, pneumonitis, hepatosplenomegaly, anemia, jaundice, and cerebral palsy for cytomegalovirus. Anyone could take a screenshot of this and share in the group, please. Done? None? Done or none?
Yes, I have done.
You have done? Okay, yeah. Good. So let's go to the next question. Thank you, doctor. So question number 15. A 5-year boy attends your clinic with his mother. She explained that several days ago he has been feverish with a runny nose and headache. The symptoms have now subsided, but is concerned about his cheeks, which have been looking flushed. Slap cheek syndrome is suspected. How long would should he be excluded from school? So slap cheek syndrome, no need of exclusion,
No
right?
exclusion. No need
Hmm.
exclusion.
No exclusion. No exclusion.
Third option.
Okay. Good job, doctor. So we'll go for other infectious diseases.
Hope we get like these questions in main exam.
You are only prepared, doctor. That's why you're feeling you want such questions, but they might be difficult for a first time reader. This patient is known to suffer from Raynaud's phenomenon. Look at the skin, it is very tight. Okay, and he has Raynaud phenomenon. So, what is the most likely diagnosis, doctors? I will not give the answers. Skin is tight, sclerosis, right? And Raynaud's phenomenon, that is Crest syndrome, right? What does the lesion on her thumb most likely represent? Arterial ulcer, gouty trophus, calcium deposit, or xanthomata. So what is this lesion? Calcinosis cutis, right? Calcium deposit. Okay, doctor, get the connection? Raynaud's phenomenon and sclerotic skin. So it is limited systemic sclerosis or called Crest syndrome. Crest syndrome
Breast
is
syndrome.
calcinosis, R is Raynaud phenomenon, E is esophageal dysmotility, S is scleroderma,
Sclerosis.
T is telangiectasia.
Yeah.
So C is for calcinosis,
Calcium.
right? So this will be calcium deposits. I hope it's correct. Yeah, this represents calcium. This is first time I'm doing this question, so I'm thinking it should be correct. Systemic sclerosis is a condition of unknown etiology characterized by hardened sclerotic skin and other connective tissues. It is 4 times more common in females. There are 3 patterns of disease. Limited cutaneous systemic sclerosis. Raynaud's may be the first sign. Scleroderma affects the face and distal limbs of predominantly associated with anti-centromere antibodies. Subtype of limited systemic sclerosis is Crest syndrome, calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias. Diffuse cutaneous systemic sclerosis. Scleroderma affects the trunk and proximal limbs predominantly, associated with anti-SCL antibodies. The most common cause of death is respiratory involvement, which is seen in 80% of the cases, like interstitial lung disease, pulmonary arterial hypertension. Other complications include renal disease and hypertension. Patient with renal disease should be started on an ACE inhibitor. Poor prognosis. So diffuse cutaneous systemic sclerosis is poor prognosis. Scleroderma, without internal organ involvement. It's only the skin that is tightened. Tightening and fibrosis of the skin may present as plaques, morphea, or linear, and antibodies ANA positive 90%, RF positive 30%, anti-SCL associated with diffuse cutaneous systemic sclerosis, associated with high risk of severe interstitial lung disease, anti-centromere is seen in limited cutaneous systemic sclerosis or breast. So these are our things. So there is shininess and tightening of the skin here also. See, look at the skin. There are telangiectasias here. See, on the lips. Can you see, doctors? This one was another spotter. A 5-year-old girl is brought by her mother. Her mom reports she started to feel unwell 2 days ago, complaining of a sore throat and headache. Overnight, she developed a temperature and vomited once. So, headache and vomiting is there, and sore throat. This morning, she has broken out a rash all over her body and has spread from her chest where it started. On examination, she has temperature 38.5 and heart rate 130. She looks flushed and has an erythematous rash all over her body, which feels like a sandpaper and blanches with pressure. There are palpable cervical lymph nodes when you examine the neck, and her tongue has a white coating over it. What is the most likely diagnosis? Sandpaper rash, tonsillitis,
Scarlet.
yes, scarlet fever. Okay, doctors? Hmm,
Yes.
okay. And on some occasions, they will say strawberry tongue also. Cervical lymphadenopathy is also there. So, scarlet fever, strawberry tongue. Mhm. This child has scarlet fever. Typical incubation period is 2 to 4 days. Typically present with fever, tonsillitis, malaise, rash. Two specific features of scarlet fever are strawberry tongue, when the tongue is covered with a white coat through which a red papillae may be seen. Later, the white covering disappears, leaving the tongue with a beefy red appearance. The typical rash in this condition starts on the torso before spreading all over the body. It has a typical rough sandpaper-like texture. Varicella causes a typical vesicular rash. In measles, the prodromal symptoms are typically coryza, conjunctivitis, high fever before the rash appears, usually starting on the head or neck. Parvovirus B19 causes slapcheek syndrome with bright red rash on both the cheeks. Adenovirus causes a lot of different infections such as respiratory infection, gastroenteritis, conjunctivitis. There's no specific associated rash in adenovirus. Scarlet fever. Scarlet fever is a reaction to atherogenic toxins produced by group as hemolytic streptococcus, usually Streptococcus pyogenes. It's more common in age 2 to 6 years, with a peak incidence at 4 years. Scarlet fever is spread by a respiratory route by inhaling or ingesting droplets by direct contact with those nose or throat discharges, especially during sneezing or coughing. Scarlet fever has an incubation period of 2 to 4 days, typically presents with fever, typically lasting 24 to 48 hours, malaise, headache, nausea, vomiting, sore throat, strawberry tongue, rash. The rash is fine punctate erythema pinhead, which generally appears first on the torso and spares the palms and soles. There is palm and sole sparing. Children often have a flushed appearance with circummoral pallor. Again, there is a circummoral pallor. The rash is more obvious in the flexures. This is often described as having a rough sandpaper texture. Desquamation occurs later in the course of illness, particularly around the fingers and toes. So this is the rash. Diagnosis. A throat swab is normally taken, but antibiotic treatment should be commenced immediately rather than waiting for the results. Management is oral penicillin B for 10 days. Patient with a penicillin allergy should be given azithromycin. Children can return to school within 24 hours after commencing antibiotics. Scarlet fever is a notifiable disease. Scarlet fever is usually a mild illness, uh, but may be complicated by otitis media. Most common complication of scarlet fever is otitis media. Rheumatic fever typically occurs 28 days after infection. Glomerulonephritis typically occurs 10 days after infection. Invasive complications, bacteremia, meningitis, necrotizing fasciitis are rare but may present acutely with life-threatening illness. So this one is a sandpaper rash. A 17-year-old girl who is a member of traveling community presents with a 3 days history of fever, malaise, myalgia, headache. Yesterday she noticed a swelling of her face which has got worse today. She described pain when chewing her food. On examination she has bilateral swelling of the parotids which are very tender. Her temperature is 38.3, heart rate is 115 and blood pressure is 112. What is the most appropriate management? They're not asking the diagnosis, they're asking management. So she is having mumps, right? And
Yeah.
what is the
Yes, it
diagnosis?
is.
What is the management for mumps? Oral steroids, supportive treatment, advised diet, rest, fluids and analgesia, arrange urgent vaccination, isolate and admit to the hospital, prescribe a course of amoxicillin.
Supportive
I
treatment.
think supportive treatment.
Supportive treatment.
Second option.
And should we notify? Yes. It's
Yeah,
a
it's
it's a
notified.
Yes,
vaccine
it is
preventable
notifiable.
disease, so it should be notified within 72 hours. So patient has mumps. Vaccination uptake may be less in traveling communities, so members are at high risk of communicable disease. Treatment for mumps is supported. There is no evidence of treatment with antibiotics as it's a viral infection and steroids are not recommended as treatment. There is no need to urgent vaccination as this patient has illness and however checking immunization status or other diseases, example rubella, measles and vaccinating as appropriate may be in the patient's best interest, but later, not immediately. Contact should be offered measles, mumps, rubella vaccination. So this is one thing. Contact should be offered vaccination. There is no indication for hospital admission in this case. Also, there was one more point which I wanted to say is, yeah, so school exclusion for measles, mumps and rubella. Who will say?
455
455, yes.
MMR. Yeah.
MMR 455, yes.
5 days. 5 days.
What is 4?
Four for measles.
After appearance of rash, 4 days, right?
Yeah. Yes.
Mumps,
Mumps 5 and rubella
5,
is also
5
5.
after what? 5 days after?
Mumps 5 after the onset of rash. Wait,
No,
mumps. Mumps है
mumps,
ना? This is after
parotid
the
swelling.
yes after the parotid onset of swelling. symptoms.
And rubella, again onset of rash, right?
Rash. Yes.
Yeah. Mumps is caused by RNA paramyxovirus. It tends to occur in winter and spring. Spread by droplets, respiratory tract epithelial cells, parotid glands, and other tissues. Infective 7 days before, 9 days after the parotid swelling starts. So, parotid swelling is a very key timeline in mumps. 7 days before and 9 days after infective period. Incubation period is 14 to 21 days. Clinical features: fever, malaise, muscular pain, parotitis, earache, pain on eating, unilateral initially then becomes bilateral in 70%. Prevention is by MMR vaccine, efficacy is around 80%. And for close contacts, you offer the vaccine. Management: rest, paracetamol for high fever and discomfort, and it's a notifiable disease. Complications: orchitis, uncommon in prepubertal males but occurs in around 25 to 30% of postpubertal males. Typically occurs 4 to 5 days after the start of parotitis. Hearing loss usually unilateral and transient. Meningoencephalitis can be there and pancreatitis. So mumps will cause pancreatitis also. Which one of the following statements regarding pneumococcal vaccine is true? Diet controlled diabetics require pneumococcal vaccine? No. Infants receive the pneumococcal vaccine at 2, 4 and 12, 13 months. PCV vaccine 2, 4 and 12, 13 months. That's right. Patients who have had a splenectomy require just one dose of pneumococcal vaccine? No, they require 5 yearly boosters. Pneumococcal vaccine should not be given at the same time as seasonal flu vaccine. Can be given, right? Why not? Both are, this is also component vaccine, this is also component vaccine. Both of them are not live vaccines. Can be given. Adults should be received the pneumococcal polysaccharide vaccine rather than pneumococcal conjugate vaccine.
I think adults should get the pneumococcal conjugate vaccine.
But in kids we are giving PCV, no? Then adults should be PPV, right? So 2 and 5 I'm thinking are correct. I'll mark 2, okay? Fingers crossed. Okay. Adults should receive pneumococcal polysaccharide vaccine rather than pneumococcal conjugate vaccine. So PCV, right? PCV we are
But
putting in vaccination
what
schedule. We'll
what
see,
is the
doctor.
difference between
Yeah, there is a
poly?
difference. There is a difference between both. I will read. I think it's there in the explanation. There is a difference between both of them. There are two types of pneumococcal vaccine currently in use: pneumococcal conjugate vaccine (PCV) and pneumococcal polysaccharide vaccine or PPV. PCV is given to children as a part of the routine immunization schedule at 3 and 12 and 13 months. So 3 and 13 months. Only two
Yeah.
times it is given. Then what is given 12, 2, 4 and 13? I think it is MENB,
Yeah.
right?
So maybe.
MENB
Yes.
is given 2, 4, 13, and this is given at 3 and 13 months. The PPV is offered to all adults over the age of 65. So, pneumococcal polysaccharide vaccine is offered to 65 years. Pneumococcal conjugate vaccine, see again here, C, PCV, C for children, C for conjugate vaccine, C is given in children. Opposite, PPV is given in adults.
Papa in children. Huh?
Yeah. Uh, uh, no. PPV is given in adults, PCV is given in children, C for children, C for conjugate. Okay. Let's remember that way. So there are two things which we need to highlight here in indications for pneumococcal vaccine. One is diabetes, this is all we know usually. One is cochlear implants is one thing which is special, and patient with CSF leaks should also be given, as well as you all know asthma with oral steroids only, and diabetes with requiring medication, not on diet control. Question number 5. Which one of the following is not known to cause acute pancreatitis? Hypocalcemia is not known to cause acute pancreatitis. Hypothermia may cause, mumps can cause, just now we have read, right? Mumps will cause pancreatitis. Hypertriglyceridemia causes pancreatitis. Steroids and hypothermia, I am not sure. Hypercalcemia will cause pancreatitis. So I think hypocalcemia will not cause. What do you say, doctors? Say something, doctors. Mumps will cause, right? Just now we read.
Yeah. Mom will cause acute
Hypertriglyceridemia,
pancreatitis.
more than 1000
And
is a very high risk factor for pancreatitis. Hypertriglyceridemia.
even steroids will cause acute pancreatitis.
Steroids will cause acute pancreatitis.
Yes.
I did not
But
For that one.
read that,
mums,
but
what
yes.
mums?
So not known to cause, doctor. Just now we read mumps will cause pancreatitis.
Okay, not now. Okay.
Ah, hypothermia, I am not sure. But hypercalcemia will cause pancreatitis, that I know. So I think hypocalcemia will not cause,
Yeah.
but I'm not sure. Hypocalcemia. Okay, hypercalcemia, not hypocalcemia, is a recognized cause of acute pancreatitis. So let's see acute pancreatitis
Good.
causes. Thank you. A vast majority of cases in UK are caused by gallstones. So pancreatitis in UK is caused by gallstones or alcohol. These are the common causes. The non-common causes, popular mnemonic is get smashed. G is gallstones, E is ethanol, that is alcohol, T is trauma, S is steroids, M is mumps, A is autoimmune, that is polyarteritis nodosa or ascaris infection. S is scorpion venom. Okay. H is hypertriglyceridemia, hyperchylomicronemia, hypercalcemia, and hypothermia. E is ERCP procedure. Procedure induced acute pancreatitis can be there after the procedure. D is drugs. Drugs causing pancreatitis are azathioprine, mesalazine, didanosine, bendroflumethiazide, furosemide, pentamidine, steroids, sodium valproate. So the drugs are azathioprine is used as a steroid sparing agent in many diseases. Mesalazine, again ulcerative colitis. Both azathioprine, mesalazine used in ulcerative colitis can cause pancreatitis. Didanosine is also what is didanosine? Something like azathioprine, right? Or diadenosine. Where did we be diadenosine? I am blank. Vendroflumethiazide is a thiazide-like diuretic. No, thiazide diuretic. Furosemide is a diuretic. Pentamidine, pentamidine again I don't remember. Steroids and sodium valproate. Diadenosine solanolipranum vidax is a medication used to treat HIV and AIDS. Okay, it's an antiviral medication for HIV/AIDS. Is diadenosine. It causes pancreatitis. Again, what is pentamidine? Anyone remembers? It's an antimicrobial medication used to treat African trypanosomiasis, leishmaniasis, Balamutha infections, babesiosis, to prevent and treat pneumocystis pneumonia in patients with poor immune function. Okay, it's an antimicrobial, pentamidine. Steroids and sodium valproate. So, get smashed. Uncommon ones: autoimmune, ascaris, scorpion, hypothermia is uncommon, ERCP drugs. So, acute pancreatitis, this is our pancreas. Node diffuse parenchymal enlargement with edema and indistinct margins. Yes, we can see that. See, the margins are very indistinct of the pancreas, whereas other organs, the margins are very clear. Very difficult to say. If you're given a CT scan in the exam, it's difficult to say that this is pancreatitis. So, yeah, last spotter. A 60-year-old woman presents with swelling just proximal to the nail bed on the left great toe. She has had a history of osteoarthritis but is usually well. This is looking like a cystic swelling. What is the most likely diagnosis? Basal cell carcinoma, epidermoid cyst, or myxoid cyst, or rheumatoid nodule?
And a nodule. Nodule will be hard.
Yeah, and osteoarthritis, why there will be a rheumatoid nodule?
Osteoarthritis, myxoid cyst, doctor.
Myxoid cyst? Could be.
I guess.
I mean, if it
Absolutely
Yes.
right. The most likely diagnosis for this patient is a myxoid cyst. Myxoid cysts are known as digital mucous cysts and benign lesions that typically occur on the fingers and toes, particularly around the nail bed, often associated with osteoarthritis and degenerative joint diseases, which fits this patient's history. The presence of a swelling proximal to the nail bed in a 60-year-old woman with osteoarthritis suggests a myxoid cyst. Not basal cell carcinoma because it has ulcerated lesion and rolled out edges. Not an epidermoid cyst, also known as sebaceous cyst. Yeah, it's not a sebaceous cyst, of course. This type of cysts are commonly found on the face, neck, and trunk, often contain keratinized material. So they're not so transparent and cystic like. Or we have seen, right, or there is a reddish swelling with a necrotic and reddish center, purplish center. Rheumatoid nodule would be unlikely, and other symptoms signs of RA should be present. And rheumatoid nodules are firm subcutaneous nodules that occur commonly in patients with severe RA. They are typically found over pressure points such as elbows or knuckles rather than the toes. Myxoid cyst, also known as mucus cyst, are benign ganglion cysts usually found in distal dorsal aspect of the fingers, usually osteoarthritis in the surrounding joint, and they may be more common in middle-aged women. So we'll go for other selection. We are done with the questions in this selection.